Hi, let us discuss about bradycardia today. So, bradycardia means slow heart, which means the ventricular rate is less than 60 beats per minute. So, bradycardia can be physiological or pathological. Physiologically, bradycardia can occur when there is increased vagal tone. This can occur in endurance training or during sleep and result in reduced cardiac output and often may even cause a syncopal attack. There are a lot of pathological causes which will be discussed. So, what is the normal physiology of cardiac pacemaker? So, we know that the normal pacemaker of the heart is the sinoatrial node. So, sinoatrial node has an intrinsic rhythm of 60 to 100 beats per minute, and it is under the control of sympathetic and the parasympathetic system. The sympathetic system increase the rate and parasympathetic system try to decrease the rate, and also there are a lot of other drugs which act on the sinoatrial node. From the sinoatrial node, the rhythm which is generated, the electrical impulse which is generated passes to the atrioventricular node. So, atrioventricular node also has its own ventricular rhythm, its own rhythm, electrical rhythm. So, this is usually at a lower rate of 40 to 60. So, if the impulse is not received from sinoatrial node, the AV node is capable of generating its own ventricular rhythm. The AV node is also under the influence of the sympathetic and parasympathetic nervous system. The further electrical conduction system below the AV node also has an ability to generate its own rhythm, and usually at a lower rate of 25 to 40. So, if the SA node is not generating the rhythm, then the AV node can take over as the pacemaker. And if the AV node is also not activating a rhythm, then the lower down parts of the conduction system can become the pacemaker. So, what are the pathological causes of bradycardia? So, one of the most important cause is sinus node dysfunction, also known as the sixth sinus syndrome. This is a condition where the sinus node is actually damaged by fibrosis, and so there is a pause in the sinus, which is known as the sinus pause. Here, the P wave is delayed. When compared to a normal ECG rhythm, the P is not coming at the right time, it's slightly delayed. This is what we call as the sinus pause. When it is so delayed so that a P is dropped, we call it a sinus arrest. Okay, so in this condition, when there is a drop of P wave, there is something called as the junctional escape rhythm, where the AV node becomes the pacemaker. In conditions where there is sixth sinus syndrome, we usually see what is called as the chronotropic incompetence. That is, when the patients are asked to exercise, usually the heart rhythm increases, right? So patients are not able to increase the rhythm in response to exercise. This is what we call as chronotropic incompetence. Another interesting condition which we usually see along with the sinus nodal dysfunction is tachybrady syndrome. In tachybrady syndrome, we know that there is bradycardia because of the fibrosis in the SA node, which produces reduced P waves. Frequency of P waves are reduced. So, in addition, there's some focus in the atria because of the same fibrosis becomes the center of arrhythmia. So these patients will develop supraventricular tachycardia. So there will be a phase of supraventricular tachycardia which suddenly stops, and then the patients will have bradycardia. So this is alternating tachycardia and bradycardia in the same patients, and usually the patients will undergo syncope when the patients develop a spontaneous conversion from atrial tachycardia like atrial fibrillation to sinus rhythm, which is actually bradycardic. Okay, this is what we call as tachybrady syndrome. And the most common type of blocks in the heart, pathological blocks in the heart, is what we call as the AV nodal block. So there are 3 degrees of AV nodal block. The first degree of AV nodal block is defined as a PR interval of more than 0.2 seconds. This is because of a slowed conduction through the AV node. This is usually not a very serious condition and does not require any treatment in particular. When we come to the second degree AV block, there are 2 types, Mobitz type 1 and Mobitz type 2. In Mobitz type 1, what happens is there is a progressive lengthening of PR interval followed by a drop of QRS complex. This is because of damage inside the AV node. Okay, whereas in Mobitz type 2, the defect is actually below the AV node. This results in a disrupted conduction. So what happens is the PR is actually constant, right? But there is random drop of QRS complexes. This is what we get in Mobitz type 2. This is a serious condition and such patients require pacemaker implantation. And coming to third degree AV block. Third degree AV block means complete atrioventricular dissociation. That is, the P waves and QRS waves occur without any relationship to each other. Alright. So what are the etiology of the different cardiac blocks which we have discussed? So most common is degenerative, that is age-related fibrosis of the conduction system, as we have discussed in the 6 sinus syndrome and sinus nodal dysfunction. Acute ischemia can also cause, especially the inferior wall ischemia produced due to right coronary artery obstruction. This can lead on to ischemia of the conduction system and also cause increased parasympathetic tone and adenosine release from the ischemic myocardium. All this contribute to bradycardia. In obstructive sleep apnea, there is an increased parasympathetic tone which can lead on to bradycardia. And in conditions where there is increased intracranial pressure, a Cushing's reflux will produce a reflux bradycardia. Infection of the myocardium in Lyme's disease and infective endocarditis can lead to conduction blocks. Infiltrative disorders like sarcoidosis and amyloidosis can affect the conduction system and produce bradycardia. In addition, hypothyroidism, anorexia nervosa, where the metabolic demand is on the lower side, and conditions like hypothermia, which can directly affect the SA node and the AV node, and hypoxemia, which can lead to ischemia of the conduction system, can all cause bradycardia. Also, some pharmacological agents like acetylcholine esterase inhibitors, beta blockers, calcium channel blockers, non-dihydropyridine, and digoxin can all cause bradycardia. So how do we treat symptomatic bradycardia, as asymptomatic bradycardia does not need any treatment? So if the patients are hemodynamically unstable, they should be treated with atropine 1 milligram, which may be repeated up to 3 times at an interval of 3 to 5 minutes with a total of 3 milligram of atropine. And if hemodynamically worsening, then we should consider the use of a pacemaker or dopamine and epinephrine. So one thing that we should note is that atropine may worsen Mobitz type 2 block. So what are the indications for permanent pacemaker? Permanent pacemaker should be considered in 6 sinus syndrome, Mobitz type 2 and third degree AV block. But you have to understand that there is a risk of infective endocarditis with insertion of permanent pacemaker, and this warrants a removal of the pacemaker and is a very dangerous condition.